Hi, this is Dr. Bernstein of Dr. Bernstein's Diabetes University. We're recording on April 28th, 2023. Before we answer some questions, we do have a number of special subjects that might interest you. The medical press recently released information on a study of the so-called zero-calorie sweetener, erythritol, that it poses a hazard for cardiac problems and strokes. Why? Well, the study involved looking first at the many prior studies of people with heart disease who were taking statins and similar drugs to lower cholesterol and other risk factors. And in the past, it was found that half the people who were aggressively treated still had heart attacks. And the authors of this study were wondering about that. And they found that many of these people, those that they could procure for testing, had high serum erythritol levels compared to zero. So they decided to look at individuals who are consuming products with erythritol, and many products do. For example, it's used in a lot of flavorings. It's used as an additive in stevia extracts that are sold that are not pure stevia. Some of them are pure stevia and others have erythritol added. So they looked at what are the blood levels of erythritol of people who are consuming products that contain erythritol, and they found out what the average blood level was, and then they took blood from people who were not consuming erythritol and mixed it with the small concentration of erythritol that the users had. And they found that the platelets in the blood were clumping together aggressively even after a small dose of erythritol. So that's the nature of the study that was performed. It was reported in Nature Medicine in, I believe, April of 2023. So it's something worth considering. And I personally would try to avoid erythritol, at least for the time being. I'm sure a lot of other people are going to be doing studies on this. Here's a question that came in that prompts a special subject. I've been a type 2 diabetic for 5 years. My A1C last month was 9.0. Problem is, I think I may have developed gastroparesis. I did the gastric emptying study and it came back normal. I don't know of any doctors in any area that can perform the RR study that you recommend. Is there anything else I can do? Well, as I've said on Diabetes University many times, and I think I say it in my book too, gastric emptying studies, which are radiographic studies where you eat a radioactive hamburger or a scrambled egg, and they then take gamma ray pictures of your digestive tract over a period of a number of hours and see how rapidly the radioactivity diminishes. What happens, well, the underlying problem is that gastroparesis has a hallmark, it's unpredictability. So someone with moderate to mild gastroparesis and even severe gastroparesis may have severe impaired emptying one day or after one meal, and normal values for the next week. So it's tough to do a study like this and catch the time when you're having impaired emptying. You might have to repeat this expensive study multiple times. It takes a half a day to do it, so it takes a lot of time, and insurance is not going to pay for more than one study. So the gastric emptying study is barely of any value. Um, we recommend uh, a study of another branch of the vagus nerve, which controls stomach emptying and digestion. The vagus nerve not only controls stomach emptying, but when it's active, it slows the heart. So every time you exhale, if you're normal, your heart slows. And when you inhale, it speeds up. So the RR study compares the heart rate on inhaling and exhaling. And it requires a doctor who has an EKG machine and knows how to do the study. Well, most doctors don't know how to do it, and they don't want to spend the time, and they don't have a technician in their office who knows how to do it. So this question is asking, what do I do if I can't get an RR study? And what I would suggest is that you get the product that we use to treat gastroparesis. And if you're getting symptoms after your meals or after one meal, you take the product, by the way, is Motilium, also called domperidone. It's not routinely available in the USA, except through a few gastroenterologists who are licensed by the government who use this product for as an experimental drug. It's been commonly used for many, many years and is available all over the world except the USA because the manufacturer of Motilium is the same company that manufactures Reglan, the biggest seller in the USA. So they don't want to compete with themselves and have to go through clinical trials to get approval for Motilium, which just is going to compete with their current product. I don't use their current product because it has a bad adverse effect profile, and I've seen many adverse effects with Reglan. So Motilium is pretty benign, and we buy it from Canada. Any physician can email or fax a prescription to Canada to get Motilium. And what you do is start taking Motilium about 90 minutes before your meals. Or if there's one meal that's especially difficult, makes you feel bloated, etc., you take it before that meal and see if it makes you feel better. And there's a classic picture of blood sugars in response to gastroparesis if it's happening. You eat a big meal and it doesn't get digested. It's sitting there. Your intestines and your stomach are not moving. So what happens? You took a shot of insulin for the meal, or perhaps some other medication, and now your blood sugar is going to drop because the food's not coming through. So you'll have a low blood sugar, and then finally, maybe 4, 10, 15 hours later, the food comes through, and your blood sugar goes sky high. That's a characteristic blood sugar picture of gastroparesis. So if you've been having that and you take the Motilium and you no longer have that, you know that you have gastroparesis. That's basically my answer to the question. Next subject is a very common problem that affects a lot of older people. It can even run in families, and it's frequently mistaken for heart attacks and other major problems, and that's postural hypotension. I'll describe the symptoms. It's in my prior videos. You may be lying down, you get up in the morning, and you stand up and you think you're going to pass out. By the way, the feeling that you're going to pass out without actually passing out is called pre-syncope. If you pass out, it's called syncope, syncope. And the prevention of pre-syncope is to sit at the edge of your bed with your feet dangling and sit for 1 or 2 minutes so that your body can get used to the blood that's pooling in your lower extremities and depriving your brain a little bit. But now if you stand up after 2 minutes, you're not likely to pass out. Now, when I was a medical student, I rotated through the medical department in a internationally famous hospital, and I was put on the cardiology ward. And almost every patient in that ward, I guess there were about 30 patients, was there for a syncope workup. They either had syncope or pre-syncope. And the doctors were ordering 4 days worth of tests: electrocardiogram, echocardiograms, stress echoes, stress cardiograms, electroencephalography, spending a fortune, keeping the patient in the hospital for a long time, where if they were diabetic, their blood sugars were mistreated. And some of these patients were put on all kinds of medications, and I saw patients actually die from excessive doses of wrong medications. And what did I do when I was obliged to admit a patient for a syncope workup? The first thing I would do would be to lie them down in a bed and check their blood pressure. And then I'd have them stand up and ask how they felt. And they felt that they were going to pass out. And while they're standing there and I'm holding on them so they don't fall, I check their standing blood pressure and it's gone way down, but their heart rate has gone up, which is a normal response. And right off the bat, I made a diagnosis. And I would tell my resident, this guy has postural hypotension. You don't have to do any further workup. And they tell me, he'd call the head of the training program. Training program would say to me, "You're here to learn, not to teach us." And to this day, people many who are going in with postural hypotension are still being given the syncope workups, still being kept in the hospital for several days. And I don't know when it's going to stop. I've seen no articles in the scientific literature admitting to this misdiagnosis that's always going on, where people are diagnosed with heart disease or pre-stroke or whatnot. I actually had one patient who was killed by this. He had postural hypotension, and I taught him to sit whenever he got up to pee at night or for any other reason, if he got up in the morning, he had to sit with his feet dangling for 2 minutes. And he was doing it. One night he forgot to do it. The wife finds him unconscious on the floor, but he actually hit his nose, had a bloody nose. And he wasn't totally unconscious. He was moaning and asking for help. And she checks his blood sugar, which was a wise thing to do, and it was normal. And the next day, she calls her son, who's a pediatrician at my medical school, where I had gone to school. Her other son, who was a pediatrician for my kids, she didn't call. And the son said he has to come in right away and see a neurologist. I told her I didn't want him to go. I called my pediatrician, the brother, and he spoke to his brother. The brother insisted he come, saw a neurologist. The neurologist checked his Doppler blood flow to the carotid artery, and it was running about 70%, which is of normal flow, which is sort of borderline, but not justification for any further procedures. However, the guidelines say if it's less than 70% and you have focal signs, you're justified in doing surgery to ream out the carotid artery. And he considered the guy's passing out a focal sign. And I called him and told him it's not a focal sign, he has postural hypotension. But the pediatrician insisted on listening to the neurologist. They did surgery on him. He had a stroke during the surgery, came out with a lisp, couldn't speak clearly. And I warned the whole family that if they do this again, because I said he's going to forget another time and he's going to pass out again, you're going to kill him. And sure enough, a year later, the same thing happens, goes through all the same business. They do a endarterectomy on the other side, even though he's getting good flow now on one side. And this time he has a stroke on the operating table, and he's a vegetable for 4 months. The wife did not want him turned off from mechanical ventilation and so on. So he cost the system and his family a fortune and didn't survive. And this thing is going on very frequently. So now you know about postural hypotension. By the way, my mother had postural hypotension, and I told, even when in her youth, and when she was middle-aged, in the summertime, she once passed out in front of Bloomingdale's department store, right out front where it was hot. And she probably had gotten dehydrated so that her blood pressure, which was usually low, was even lower. And fortunately, she had the medics who came along call me, and I told them she has postural hypertension. Get her a glass of salt water somehow. And they got it, and she recovered and walked away. And I, thereafter, had her keep next to her bed a glass of salt water. When you get up in the morning, you sit up, drink half the glass, and then you stand up. One day she forgot to do it. She calls me, I can't stand up. Did you drink the water? Forgot. Drink the water. And just wait a couple of minutes. Felt fine. Next problem has to do with foot care. I got a phone call about 3 weeks ago from a lady who wanted medical advice. She had a crack along the bottom of her foot, went from the toes, the base of the toes, all the way almost to the heel. And she said that it burned a little, and she had taken it to a podiatrist, and he didn't know what to do about it. And I said, well, if I give you medical advice, then I'm part of your medical team and I'm responsible for anything that happens to you, whether it has to do with this foot crack or anything else. So I can't do that. But I'll try to answer your question on my next video. So I'm going to now try to tell everybody what would you do to heal this. And it's all common sense. First of all, I would not put alcohol or beta. By the way, the podiatrist told her to put alcohol on it every day, rub some alcohol swabs. So I told her alcohol and betadine, iodine, kill the cells that heal the wound. So you're going to perpetuate the wound if you use products like this. However, there is a product that has been very successful for many, many years. It's approved by, it preceded aspirin, so it's never, and it's a generic drug, so no one ever submitted it for approval by the FDA for humans. And one of the brand names is called Microcyn, Microcyn, and you could see it on the internet, on Amazon. It comes in a spray, liquid or gel, and may even come in an ointment that you can rub on. And it's a derivative of bleach, but it's not bleach. It's a fantastic antimicrobial that promotes healing. And it's amazing how rapidly wounds heal. And the veterinarians have been using it for years on dogs who get wounds, even on their feet, on their paws. So I would spray this thing with the Microcyn or rub it on with a swab. And then I would take either steri strips. Steri strips you can buy at pharmacies or at surgical supply dealers. They're very tight sticking strips of adhesive that are used instead of suturing for closing minor wounds. You could also use, say, paper adhesive tape if you get a fresh one that's nice and really sticky, and use it to hold the sides of the wound together. So here you're holding the wound together with either adhesive tape or steri strips, and you do multiple strips along the length of the wound, let's say every quarter inch or half inch, and it's going to hold it closed. And the Microcyn, it's also called Vericyn, Microcyn, all have names ending in SYN. It'll rapidly heal. But this reminds me of another problem that has to do with foot wounds, and a recent article that just came out in one of the journals. When it's been common practice when a diabetic has a wound in the feet that's slow to heal and has confirmed poor circulation in the feet, the surgeons want to do what's called a fem-pop bypass. They want to they assume that the popliteal artery that supplies the lower leg, begins in the back of the knee, um, is blocked or partially blocked, and they connect it to the much larger artery, the femoral artery, which is a little higher up, to give it more blood flow, uh, supposedly to save the leg. But years ago, I learned that's usually not what happens. If you take, if there's a wound and you take proper care of it to heal it, and it takes time, you wait the time that it takes, and if you're doing the right procedure, it'll heal. But what happens if you do a fempop bypass? While this leg has been slowly the arteries have been slowly blocking over a period of years, maybe a half a lifetime. So collateral circulation has developed to keep the leg alive. And when you do a fempop bypass, you suddenly are letting a lot of blood into the major arteries of the leg, and the pressure in the capillaries goes down to zero because they don't have to open up. The big arteries getting enough blood. So the collaterals close down. You now have no collaterals, and you have an artificial connection to the femoral artery. And historically, these artificial connections tend to block, usually at the point where the two arteries are joined together. And when they block, there's no collaterals. So you now have a cold, dead foot, and you're going to need a new bypass right away. But here's the patient, he's home, he may be 10 miles from a hospital, and even if he were around the corner from the hospital, he has to find the vascular surgeon, get him off the case he's working on, and come and do his case for an emergency bypass, which just doesn't happen. And historically, when a diabetic loses a leg, especially if it gets cut off high up, the life expectancy drops to 5 years. So and it's usually, they say 6 months to 5 years. So usually 6 months to 5 years, the patient may survive. We had my chief, who founded the Peripheral Vascular Disease Clinic that I eventually became chief of, took me around to a nursing home in the Bronx, where he was in charge of the PVD, Peripheral Vascular Disease Clinic. And he had regular visitors, people who lived in that home would come, let's say, every couple of weeks or once a month for him to inspect their feet and their circulation and so on. And there was one guy who wasn't there this week. And he asked the nurses, what happened to so-and-so? And she said, well, the surgeons from the big hospital came and took him away. And my chief says they're going to kill him. And he starts to cry. This 70-year-old guy from Germany starts making phone calls tries to track him down in the hospital, and the hospital has no record of him. He continues to try to track him down. They get his home. He had the surgery, and he died the next day. They amputated the leg because he rapidly developed a cold dead leg. They amputated it, and then he died. So, and my chief, whose name was Heinz, started to cry. Next subject. I made a discovery which I'd like someone else to confirm. I usually keep in my bathroom in a Frio pack at night a syringe with a little bit of Humalog, super rapid acting insulin in it, and a long needle for an intramuscular shot if I have to correct an elevated blood sugar. So if my blood sugar is let's say 120 or above, and my target is 83, and it's been many hours since I last had a shot of fast-acting insulin for a meal, I will give an intramuscular shot of 1/4 of a unit of Humalog, which is the fastest insulin I can find. And I just leave it there so I don't have to, at 4 o'clock in the morning, start getting a bottle out of the refrigerator and going through the gymnastics. And there, all I have to do is push out a little excess Humalog, and then when there's 1/4 of a unit left in the syringe, inject it. And I don't even have to do that. It's preset at 1/4 of a unit, which is the lowest I could estimate. Well, what I've been finding is that although they're kept cool, the insulin's kept cool in the Frio pack, it's in the syringe, it doesn't work when I use it. So if I've pre-filled the syringe, something happens when you have a very small amount, and that tiny amount, 1/4 of a unit, kept cold overnight, doesn't seem to work. Now, I don't know, I've not asked any other diabetics about this, but maybe some listeners can try doing the same thing and see if Humalog insulin spoils if you have only 1/4 of a unit in the syringe and keep it overnight in a cold pack. And it doesn't freeze it, just keeps it cold. Okay, there's a new study that was published in one of the diabetes journals. This looks like Diabetology, I think. Let me see with a magnifier what journal this is. It might be Diabetes Care. That glomerular hyperfiltration precedes diabetic kidney disease. Now, Diabetes Care, and this was in April of this year. Years ago, an investigator, Barry Brenner at Harvard, said that high protein diets cause diabetic kidney disease because they cause the kidneys to overwork. to hyperfilter because the kidneys are busier when you eat protein. And I argued with that, and I was ridiculed by many diabetologists, and was considered crazy because I challenged a guy from Harvard, Barry Brenner. He subsequently retracted his study at a kidney conference where he found that rats given a high protein, low carbohydrate diet lived longer, not shorter lives. But now this argument comes out in diabetes care, and it looks like a good argument to say that Bernstein was wrong. However, this study did not tell whether the hyperfiltration was a cause of the kidney disease or whether the kidney disease caused the hyperfiltration. Because when you have vast compromise of the blood vessels, you have a change in the diameter of the incoming and outgoing arterioles of the kidneys. There's one little artery going into a kidney and one coming out. And if you, let's say, dilate the incoming artery, you're going to have more blood flowing into the kidney. And if you also dilate the outgoing, you'll have more blood flowing out too. So the diabetic kidney disease does involve changes in the afferent and efferent arterioles of the kidneys, and that could precede the hyperfiltration. So this article does not, and it does, and says nothing about diet, by the way, the article. So it cannot be used as evidence that Bernstein was wrong. Here it is. Okay. Another study from Diabetes Care points something out that I didn't realize, but it's new information. They did MRI studies, that's visual imaging, of brains of people who had peripheral neuropathy in their hands or feet. So they had numbness or tingling in their hands or feet. And they found that there were changes that could be seen in their brains, including smaller size, of people who had peripheral neuropathy. Now, whether the neuropathy caused the changes in the brains, whether the changes in the brains caused the neuropathy, or whether they were both consequences of high blood sugars, which is, in my mind, more likely, it's just new information. Now there's a study, I'm surprised that it wasn't done long ago, that seems to elucidate something we all knew anyway. They looked at the effect upon blood sugar of three types of exercise. What they called cardiovascular, which would be running or doing rapid calisthenics. Strength training, which is weightlifting, and a mixed, where you'd do weightlifting while you're running around, which makes your running slower. And as my patients and myself have observed, the running, the dynamic exercise, or cardiovascular as they call it, lowers blood sugar the most. The intermediate exercise lowers it in between, and the weightlifting lowers it the least, and many people find even no change with the weightlifting. And this was confirmed by a study published in Diabetes Care. Here's a little tiny article here. Avoid early peripheral vascular intervention for stable claudication. Claudication is, they usually call it intermittent claudication, when a patient walks a block and he can't walk anymore. His muscles don't move. He usually gets pain in his calves, and there's so much pain that he has to stop. And he stops and rests for 5 minutes. Maybe if there's a bench nearby, he sits down, and he can now walk again. And it's called intermittent because the claudication stops once you get a rest. And it has to do with the fact that there's not enough blood flow to the muscles to keep going. And I remember we saw many of these patients in clinic. We had devices for checking their circulation, and the one I'm wearing, by the way, is a Doppler stethoscope, which is used nowadays to check circulation in the legs. And what we found was that we could give these people a couple of grams of L-arginine and 2 grams a day, and they'd be able to walk 2 blocks instead of 1. And if we gave them exercises to do every day that involved toe presses, heel raises, a few exercises of the foot and legs, we could increase the distance that they could walk. I had one person I dealt with recently who initially could walk about 300 feet, and after a couple of years of exercising, pushing weights with his feet and whatnot, he now can walk an indefinite period, a mile, without getting claudication. However, doctors are still doing fem-pop bypass grafts for people who have intermittent claudication. And now someone did a study where they found that doing this killed people. They'd lose their legs and then die. So you do not do bypass grafting for intermittent claudication. So I've been vindicated. Ah, here's another article, I guess again from Diabetes Care, again out of the blue, reiterating something I've been saying for years and years, almost as long as I've been in practice. Importance of beta cell mass for glycemic control in people with type 1 diabetes. It is so much easier to treat a person who still is making insulin, who has beta cells, than it is for treating someone who's burned out all his beta cells. And a major goal in treating a newly diagnosed patient who's still making insulin is to preserve those beta cells. And right at about the same time as this article comes out, there's an ongoing study of a new antibody that's being tested in an effort to get FDA approval for preserving beta cells in newly diagnosed type 1 diabetics. And we got a phone call about 2 days ago from a mother who wanted my opinion on whether she should enroll her son in this study. I said, I thought that the study was over, that they're going into the next phase of it or next step, and that you can't get in. She says, well, her husband has some influence. He'll pull strings to get him in. I said, well, I don't know about it. I can't. If I gave you information, I'd be part of your medical team, and I'd be responsible if something went wrong. So you just have to keep up with the literature or ask your own doctor. Do you have a diabetologist? Yes. So ask your diabetologist. However, they point out that this antibody works by preventing the production of tumor necrosis factor alpha, which is an inflammatory agent. And since the inflammatory system is what kills infectious organisms, one would think that the users of this drug might be more susceptible to infections. There was a small study because they were using maybe around 100 people, not thousands of people, and none of the users had any more infections than the non-users. So that was good news, but you can't be absolutely certain until you do larger scale studies. If you get invited to participate in a study, I don't know what to tell you. However, there were several articles in the Journal of the American Medical Association pointing out that verapamil, which is an anti-blood hypertensive drug, is effective in preserving beta cells in about a third of the users. So I've been prescribing verapamil for my recent onset type 1 diabetics who still are making insulin. And we've had some degree of success. I can't say whether it's because of the verapamil or because I seek normal blood sugars, because high glucose levels destroy beta cells. And by keeping blood sugars normal, you're helping preserve the beta cells. So you could check issues of the Journal of the American Medical Association in April to see the reports about verapamil. We're now going to answer a few questions, but I want to remind you that the answers I give are generic answers for the listeners. they might not suit the exact problem of the person who submitted the question. I haven't examined that person. I've not gotten a full medical history. I don't know what medications he's taking, et cetera, et cetera. So he should, the questioner, he or she, should could consult the private physician before proceeding with anything that I suggest here, because this is just my guess, and it's to educate you. What do you do when a patient who will be following your diet, no, who has been following your diet plan for 2 months and has his lipid panel done, and total cholesterol and LDL and non-cholesterol values are very high? Well, what he's checking are non-predictors of anything. It was long ago shown that total cholesterol does not predict anything, but there are certain forms of cholesterol, like that might be predictive of heart disease or strokes, for example, and also LDL. Total LDL, there's good LDL and bad LDL. So the good LDL is the large buoyant LDL. The bad LDL is the small dense LDL. So what you want to look at is the proper predictors. So we look at things like oxidized LDL, small dense LDL, lipoprotein small a, which, as I've said before, in my experience is the biggest predictor, but there are problems with lipoprotein small a is because it shouldn't be the specimen shouldn't be frozen. It's unstable. Different methods give different results, and then there are inflammatory markers that can be checked that also are more predictive of heart disease. So you should look at the things that have meaning, not the things that don't have meaning. My doctor, who follows my type 1 diabetes, tries to convince me to eat sweets, and that a blood sugar between 80 and 180 milligrams is considered normal. Your thoughts? Well, you've seen from my videos where I've shown articles that people with slightly elevated blood sugars get the long-term complications of diabetes. So why should you be exempt? You might want to consider a physician who believes in normal blood sugars. Have you noticed that low-carb patients and mineral or vitamin deficiencies, and do you have any recommendations regarding possible deficiencies? In my book, we have a list of, I think, something like 45 different low-carb vegetables. If you eat seafood, fish, eggs, dairy products, the low-carb vegetables, it's hard to have a vitamin deficiency on the one hand. On the other hand, if you live in an area where you're not being exposed to sunlight, you might have a vitamin D deficiency. And I find that almost every patient whom I've treated um, has had low vitamin D levels or low normal levels. It's rare that I find someone, uh, let's say, in the middle of the normal range. So most of my patients I give small vitamin D supplements to. Um, there's also a possibility of magnesium deficiency if you are very restricted in what you eat. I've seen that in some vegetarians, uh, so I guess um, uh, meat products may have some magnesium, or fish products, um, and you can determine that by um, measuring both red blood cell magnesium and also serum magnesium, both. I would like to understand more about managing low-carb diet and protein and fat. Can it be done with fast-acting as opposed to regular insulin? Well, the fast-acting insulins like Humalog came about because it was realized that the high carbohydrate diets weren't working. And doctors speculated that, gee, if we had a faster insulin to work as fast as the carbohydrate, maybe we could control blood sugars. But it never worked. The faster insulin that came along, Humalog, um, was also much more potent than regular. So it was hard to adjust fine doses unless you actually diluted the insulin. So occasionally we come upon a patient where indeed the Humalog can be taken before a meal. For example, I have several type 2 diabetics who take Humalog before their meals, small doses, usually diluted, um, and it seems to work. Um, they may take it, some take it 5 minutes before a meal, some take it a half hour, some take it 45 minutes before a meal. It all depends on the individual. It seems that for some reason, some type 2 diabetics absorb the rapid acting insulin more slowly. Now, I have one type 1 diabetic who eats lunch in school, and because of their program, doesn't know exactly when he's going to eat lunch. So we have him inject when he goes to the lunchroom and takes his lunch out, and he injects immediately before eating, and he gets diluted Humalog so that he'll be able to measure the dose more precisely, and it seems to work out. But that's a rare situation. And by the way, he's also still making insulin. And the reason why this may work with type 2 diabetics is because the ones I'm treating still make insulin, and therefore they don't have to take very much Humalog, and it's diluted. So they're depending mostly on the insulin that they make. Well, here's a long question. I usually don't answer that long questions, but let's see. I was diagnosed a year ago, age 23, with type 1 diabetes. My A1C was 14, and my blood sugar was in the 500s. My mom found your book, and we immediately started your protocol. At appointments, we were instructed to eat lots of carbs at each meal and take insulin on a sliding scale. Thankfully, your book educated us in a different direction. After 3 months, my blood sugar was normal to the point it was dangerous to take insulin. Within 5 months, my A1C was in the normal range. And at 1 year, I am off insulin, but have it on standby in case I need it. My C-peptide has gone from 0.51 to 2.32. Which C-peptide is a measure of how much insulin he's making. My A1C is 5.5, and my blood sugar is in normal range 99% of the time. What are your thoughts? My thoughts are that to preserve beta cells, you want to keep your blood sugars really in the normal range. If he hasn't told me what he calls normal range. If he's calling normal range what the ADA calls normal range, which is up to blood sugars of 180, that ain't normal. So you might need small amounts of diluted insulin. Maybe it's diluted regular before one or more of the meals. You see what's happening to your blood sugars at 1 and 2 hours after meals. Are they going up temporarily and then down? Maybe you could use regular insulin or diluted Humalog to prevent those peaks. If it looks like you need some basal insulin, you might want to try a quarter of a unit of Tresiba. You might need it once a day, twice a day. It all depends on your blood sugars, and it pays to take frequent blood sugars during the day so that you could spot any peaks. Alternately, you might want to get a continuous glucose monitor. So it's so important to preserve the beta cells and your C-peptide measurement really is dependent upon your blood sugar at the time you take the test. So you could take a non-diabetic and have him fasting for a day so that his blood sugar can be maybe 75 or so, maybe 80, and his C-peptide will be low. And then you give him a bottle of liquid glucose to drink, and he could go up to 150 or higher, and his C-peptide will be sky high because the body's trying to offset the high blood sugar. So C-peptide measurement is very dependent upon what you've been doing, especially what you've been eating. But just remember how important it is to preserve insulin production. Okay. Do you know of any tricks to cooking potatoes and pasta so that I can eat them and keep my blood sugar at 95 milligrams per deciliter? Okay. There happens to be a liquid potato extract that you could try pouring on mashed cauliflower or maybe on tofu. So if you look on the internet, look for potato liquid extract or or mashed potato liquid extract, and it's there because I found it. That's about the closest you could do. There's no trick. I have no idea how much this stuff costs. It might be expensive, but if you crave potatoes, it might be worth it. That's it for now. Good luck. Thanks for watching.